All right, good morning and welcome to the Department of Medicine Grand Rounds. Today we have three of our Chief Resident PGY3 in Medicine speaking to us about update to the management of alcohol withdrawal syndrome. Dr. Shamal Khattak, who is going to stay with us here at MAC for cardiology starting next year. Dr. Barbara Gunka, who is also staying with us for hematology, and Dr. Carter Winberg, who's leaving us to Western. Maybe he can come back after he finishes his ICU training there. They are supervised by Dr. Leslie Martin and Dr. Suzanne Turner. Without further ado, I will pass it on to our wonderful speakers.
Okay, so hi everyone. As Dr. Zan said, we'll be talking about an update to the management of alcohol withdrawal syndromes. We just wanted to start with a land acknowledgement. So we recognize and acknowledge that we are located on the traditional territories of the Mississauga and Haudenosaunee nations and within the lands protected by the Dish with One Spoon Wampum Agreement. So going over our objectives for today's talk, we'd like to describe the incidence and prevalence of alcohol use disorder and withdrawal in Canadian populations, look at the currently available scores for predicting the severity of withdrawal, go over some updates to the treatments of patients presenting with acute alcohol withdrawal syndromes, focusing specifically on the use of Phenobarbital, and look at briefly at the continuum of care beyond the acute setting. So we just want to start the presentation by highlighting a case. So I think this case, many of you would agree, is quite typical of something that we would see on our internal medicine wards. So it is of a 55-year-old gentleman who's presenting with features of pneumosepsis. When you take your social history, he reports that he drinks 5 to 10 tall boys per day for the last 20 years with no periods of abstinence in between and no prior history of withdrawal. He's placed on the CIWA protocol by the admitting internal medicine resident. Over the course of the next 24 hours, he requires quite a few doses of IV diazepam, up to 10 milligrams per hour. He's so agitated that he cannot take oral medications, but he continues to have a high score on the CIWA-Ar score. And this ultimately means that he cannot be transferred to the ward due to hourly benzodiazepine requirements. So the question that we hope to address with this presentation is, what should we do next in a case like this?
So we thought we'd start off with some definitions. And so alcohol use disorder actually comes from the DSM-5. And really, it's a problematic pattern of alcohol use leading to clinically significant impairment or distress. And looking at the DSM-5, there are actually 10 criteria, and you have to meet at least 2 of them within a 12-month period. And we can kind of look at most addictions, including alcohol use, with the 4 C's. And so that would be cravings, compulsions, consequences, and control. And so that would be things like being unable to cut down, having a strong craving, and maybe having recurrent alcohol use that results in failure to fulfill major role obligations, such as things like work, school, and home. Next slide. And so alcohol withdrawal essentially happens when people stop drinking or significantly reduce their drinking after long-term dependence. And there's I think most internal medicine physicians or even people rotating through would understand that there is a broad range of presentations from mild tremors to severe consequences like seizure and death. And this is also defined in the DSM-5. And so here we look at the ED visits for conditions entirely attributable to alcohol, and this comes from Public Health Ontario. We can see that in Ontario, people living in rural areas, more towards the northern regions, report higher rates of heavy drinking and have higher rates of ED visits entirely related to alcohol. Hamilton, although hard to see on this map, does actually fall in sort of that 527 to 596 ED visits per 100,000. And so we definitely are on the higher range. And we do know that in Ontario and in Canada, actually, more than 20% of people aged 12 and above do report heavy drinking. And so looking at the system's impact of this, I was kind of shocked to learn this, but the cost of alcohol-related harms is $14.6 billion annually. And when we look at breaking that down, that's $6 million for lost productivity due to disability and death, $4.2 billion in healthcare costs, and then $3.2 billion in criminal justice spendings. And when we compare this to things that we're seeing pretty often, COPD costs us about 1.5 billion per year. And in 2030, they actually think heart failure is going to be projected to cost us about 2.8 billion. And so, we see that quite frequently, and alcohol is actually a bigger expense on our healthcare system than very common presentations. And we do expect that the per person healthcare costs associated with alcohol will increase approximately 25%. They did increase 25% in the last 10 years, and about 1 to 2% of all emergency department visits are related to alcohol. And there have been studies to show that the use of alcohol as well as alcohol withdrawal have peaked with the COVID-19 pandemic. And deaths have also increased in that time frame, about 25.5%.
So I'm just going to speak a little bit about the clinical scores for predicting the severity of withdrawal, including kind of the changing landscape that we're seeing anecdotally in the use of these scores. So I'm sure that we're all very familiar with the CIWA-Ar score, which is the score that we use here for all our admitted inpatients that are at risk of withdrawal. So this score has been translated into over 20 languages. It's used worldwide. It was first developed in the 1980s in Toronto, initially as a 15-item scale, and this AR abbreviation at the end for alcohol revised refers to a shortened 10-item scale that is now the most commonly used scale in our institutions. So with the CIWA-Ar score, next slide, Carter. So this is kind of what the score looks like. So all domains are scored between 0 to 7, except for orientation and clouding of sensorium, which is scored between 0 to 4. And these thresholds are according to our protocol, but different protocols in other institutions may use the score with different thresholds. So classified as greater than 8, less than 8 would be absent or minimal withdrawal, 9 to 19 mild to moderate, and greater than 20 severe. And the way that our protocol is set up is that if someone triggers a high score, meaning greater than 8, they would receive 4 milligrams of lorazepam or 20 milligrams of diazepam every 1 hour as needed. But the protocol does max out at maximum of 3 doses, after which point nurses are required to call the MDs for further dosing of benzodiazepines from this protocol. So going over some of the strengths and limitations of this score. So it is widely used, available in many languages, as I said. It's symptom triggered, so it doesn't depend on a fixed dosing schedule of benzodiazepine. It's longstanding, so there is a lot of evidence for decreased frequency of oversedation, as well as lower incidence of delirium tremens and shorter hospital stays. However, it is highly subjective. Only 3 out of the 10 components of this score that were present in the last slide actually are objective measures, and that includes the tremors, paroxysmal sweats, and agitation. The remainder tend to require some discussion with the patients, in which case it's limited by potentially by language barrier or confusion delirium. So for example, if you have a patient in which there is a significant language barrier, who would need frequent reassessments on this score, it would essentially require the use of a 24-hour translator, which is not really feasible in a lot of instances. So there are these few limitations that have come up in clinical scenarios in terms of using the score. So in looking at some more recent evidence for comparing and contrasting different clinical prediction scores that are out there, because there are other scores beyond just the CIWA score that are in use. So there was a JAMA Rational Clinical Exam that looked at this in 2019. So they compared and contrasted scores that predict the development of severe alcohol withdrawal syndrome. They found 14 high-quality studies that met their inclusion criteria with a total of over 70,000 patients. They looked at both individual findings that predicted the risk of alcohol withdrawal, severe alcohol withdrawal, and they also looked at scores as a combined finding. For this, they defined severe alcohol withdrawal syndrome as significant psychological or autonomic symptoms, presence of seizures, or presence of delirium tremens. There were very few individual findings that on their own had a positive likelihood ratio, and even those were relatively low. So the best that they found were patients who had a history of delirium tremens on previous admissions, 3 or more seizures during the current admission, and a systolic blood pressure of greater than or equal to 140 millimeters mercury. None of these are included in the CIWA score. When we look at, on the next slide, the scores that they compared and contrasted, there were 3 scores that were represented in their 14 study sample. The CIWA score was used in 7 of the 14 studies, but because of variation in threshold values, it did not meet kind of criteria to be valued in meta-analysis. So for example, we use a cutoff value of greater than 8, but some studies that kind of reported CIWA scores as predicting development of withdrawal used cutoffs of greater than 15 or greater than 10. So because of that variation, it was difficult to assess. They actually found that among the composite measures, there was this prediction of alcohol withdrawal severity scale, or PAWS, a scale that had the best positive and negative likelihood ratio and relatively good sensitivity and specificity. I did include the score here on the side that you can see. So it includes objective measures of increased autonomic activity, including heart rate, tremor, sweats, agitation, nausea. And it includes things like previous delirium tremens, previous alcohol withdrawal seizures, which were individually found to have positive predictive value in terms of predicting severe withdrawal. And there are, certain parts of the score that are less dependent on discussions with the patients or subjective measures. But going forward, sort of where do we go from here? This was their bottom line. So that I think, few individual symptoms or signs predict withdrawal effectively, but that the PAWS score performed the best. This study did have quite a few limitations. So obviously few studies overall in terms of the studies that they screened were actually included based on their inclusion and exclusion criteria. And the only score that really had the best bias protection was one of the scores that didn't even end up being discussed in a lot of detail, which was this QADA score that is used in certain institutions. And obviously the inability to really effectively look at the CIWA based on the different threshold values was another limitation. So I think I was kind of left with a feeling that it wasn't like we don't have a great sense of an alternative tool that as yet exists to the CIWA score that has a really good evidence base behind it. And I do think that realistically implementing a new tool in our hospital systems will be quite difficult, given just the costs associated with that, the retraining of staff members who administer and who assess patients for meeting criteria on these tools. So the question is, can we instead bypass the limitations of the CIWA score in a more practical way? So this is where there has been newer kind of emerging evidence and anecdotal support for this objective alcohol withdrawal scale that was developed initially by the addictions medicine physicians in Vancouver and is used out there quite a bit, as I've heard, but is starting to be adopted here by our addictions medicine physicians. So this score looks at, and this is just an example of the score that they used in the study that I've highlighted here. But there isn't as yet a very defined version of this score. And they even mention in this study that they tend to change the scoring criteria and the dosing depending on whether or not certain objective measures are explained by other conditions. So they provide a score for systolic blood pressure greater than 160, heart rate greater than 90, tremor, diaphoresis, agitation. So looking only at the objective measures of withdrawal. And then, as I said, this was the protocol described in this paper, but that they even acknowledged that this would change accordingly. So for example, if the patient had uncontrolled atrial fibrillation, they might use a higher cutoff for the score because they would score positive on the heart rate, whether or not they were in withdrawal. So this is just an example of a score that is starting to be applied, but I think as yet does not have a strong evidence base behind it. So moving kind of to the next portion, in terms of how do we apply this? So it's not intended as an alternative to the CIWA score, but it is sort of an adjunctive measure that can be useful when our other tools and the CIWA score cannot be reliably applied. So for example, in delirious or confused patients, in patients with a significant language barrier who may have mechanical communication problems such as facial or jaw trauma, or in intubated patients. So, I think that next steps, we probably will have continued use of the CIWA score, but with a recognition of its limitations, including scenarios in which it may be limited or inaccurate, and recognizing when benzodiazepines may be underdosed, because there is that, sort of maximum of 3 doses, and then the rest is up to the discretion of the physician. So I think in those cases, supplementing with this score might be useful, and that's kind of the next steps from here. Okay.
So then if we move into kind of what to do with that information and what to do with the information gathered from severity scores, we'll talk further about updates in management on alcohol withdrawal. As a medicine resident, we get these pages from like post-surgical patients, patients coming out of ICU, people already admitted to our ward, and from the emergency department who kind of fit this criteria of symptoms, have a history of alcohol use, and we are able to label this alcohol withdrawal. And then I feel we have a reaction and a reflex that is just benzo, benzo, benzo. And if you've been working at HHS recently, you might have gotten the EPIC notification when you're ordering IV Ativan that there is a critical shortage. And are you sure you really want to use this? And it kind of got us to thinking of what other things are in our toolkit. What else would we be able to do if we actually didn't have this medication to reflexively use? So if you actually go back in history, you see that benzos are a more recent addition to our toolkit. Back in 1846 is when von Baer developed barbiturates, the gentleman that kind of went on to develop the Bayer company that we know today. And it's not till years later in 1911 when they have barbiturate derivatives like phenobarbital invented, which really kind of takes off and becomes widespread use in an inpatient and acute setting as well as an outpatient, and is the standard of care in alcohol withdrawal, and particularly used widely across Europe at that time. And it's not till 1960 when we get our first benzodiazepine in Librium. And around that same time, you have a lot of advertising about the benefits of benzodiazepines in contrast to some of the negatives we're realizing at that time about barbiturates, and that they have a dependence and addiction potential, as well as you're seeing lots of people having respiratory suppression and overdose at significantly high doses of phenobarbital as an outpatient, most notably with the death of Marilyn Monroe in 1962. Then we move today where benzodiazepines are really the standard of care in alcohol withdrawal, and their efficacy has been shown in multiple trials and even through a Cochrane review done by Dr. Holbrook here a few years back, showing that they do work. But you'll see nowhere on this timeline is there a moment where there's kind of a groundbreaking large multi-center RCT that is changing care. It's more so a shift of culture towards benzodiazepines. To then speak about which medication to use, I think you have to have some understanding of what you're trying to target and what you're trying to treat at that time. Very simply put, the alcohol withdrawal state is characterized by when you pull alcohol away, you no longer have that depressive effect that you get through stimulating your GABA, as well as ethanol will bind glutamate, which is an excitatory molecule. So you're taking that away. You have an increased excitatory molecule and a decreased amount of depression. Phenobarbital has some unique properties here. Both phenobarbital and benzodiazepines bind to the GABA receptor, but where benzodiazepines bind and increase the affinity for GABA, so they're relying on the precursor of GABA, barbiturates bind and open the channel and allow the influx of chloride ions independently of that precursor, which might, the theories there would be that this is why it leads to kind of a greater CNS effect, or why you don't see kind of resistance or people that require different doses of phenobarbital, where we've all seen patients require quite significantly different doses of benzodiazepines. The other unique thing is on the right side of the screen, you'll see the AMPA receptor, which is one of the receptors that acts on the glutamate pathway. It will also bind here and reduce the activity of glutamate, so able to affect both of those things that we discussed on the last slide. One other interesting pharmacodynamic property of phenobarbital is its linear correlation in dosing. So you can see that the amount that you give directly and linearly corresponds to the serum concentration when you draw a level. This is a valuable property when you're worried about significant side effects like respiratory suppression, that you'll know when you're going to hit a toxic dose, and you can reliably know what's kind of going into your patient as you dose your patient. As I mentioned, there isn't any one trial, so then the question is, has our understanding or our evidence kind of changed over time? Early on, there was data. The more notable one would be in 1978. There was one head-to-head trial of benzodiazepines and phenobarbital in a very small population, but it was a small controlled trial that showed some early favoritism towards phenobarbital, but really a significant lack across time of head-to-head trials. And again, no large, big trial data. What we do know is that there is an evidence of safety in the use of phenobarbital in the acute setting, with multiple trials showing that they can be used effectively in the right patient populations. In 2016, we had a systematic review looking at specifically barbiturates and alcohol withdrawal, looked at a total of 15 studies. These studies are very different in the way they use phenobarbital and what they're comparing to. So overall, the kind of takeaway from the systematic review is that all these studies are small, nearly all of them are retrospective, and they're very heterogeneous in what they compare to and the dosing of phenobarbital and how they're combining other medications with phenobarbital. They do feel confident in saying that it was a safe medication with low rates of respiratory depression, and even 3 trials showing reduced intubation rates. Overall, they kind of summarize this as a small but encouraging body of evidence for the use of phenobarbital in the setting of alcohol withdrawal. I'd then like to highlight a few other trials that have kind of come out more recently. The first one here by Rosenson was actually included in that systematic review, but I pull it out because it is a randomized control trial, but only of 100 patients, where you're comparing phenobarbital use to our standard CIWA protocol with PRN benzodiazepines, and they showed decreased ICU admission rates. And then in a similar style with phenobarbital versus your CIWA score and PRN benzos, you have a retrospective review by Tidwell in 2018 that showed favorable results to phenobarbital with decreased ICU length of stay, hospital length of stay, and again, intubation rates. And then if we move in, there's 2 trials in 2019 that follow very similar formats. They're retrospective cohort trials of 500 and 200 patients, where you're looking back and finding which patients received phenobarbital. Now, all the patients that are receiving phenobarbital in these centers are the high-risk refractory cases of alcohol withdrawal. So really, you're dealing with a significantly higher risk group of patients. And in the Nisovic trial, you're seeing equivalent outcomes. And in the Sullivan trial, you're seeing favorable outcomes to phenobarbital being introduced with decreased hospital length of stay and decreased symptoms at 24-hour. But I would note that even when it's equivalent, I think this is a win for phenobarbital being added to the therapy, given how significantly high risk these people are with either a history or ongoing kind of delirium tremens, seizures, and persistent severe symptoms. So if we were to try to take some of this evidence and think about how would we use these medications, there's certainly some like practical considerations of what we need to know about these medications. The pharmacodynamics with the long half-life that's in the matter of days allows you to kind of reach a steady state and then try to work within that versus the sometimes more roller coaster up and down effects of shorter acting medications. And it is helpful to know about these predictable levels and predictable effects that we can see with phenobarbital. It should have significant ease of access where PO phenobarbital is incredibly cheap. And it is a WHO universal medication, so we should have access to this medication kind of across sites and not only in larger centers. And it can be administered in a variety of ways, IM, IV, PO, and PR. Then there's a question of will there be secondary benefits of using phenobarbital where we know that there's going to be benzodiazepine treatment failures. We would not expect that with our phenobarbital patients. And theoretically, though this hasn't been kind of documented in many major studies, we would expect to see a lower seizure risk, as well as trying to avoid the paradoxical agitation and delirium we sometimes see in the aftermath of significant benzodiazepine use. Barriers to using it or trying to recognize which patients it'd be more appropriate for, I think you need to think of how this is a long-term commitment to the GABA receptor. So if you are unsure about this diagnosis, or you're just seeing some symptoms that could be in keeping, and on their EPIC chart, there's a history of alcohol use, but you haven't really clarified that, I think you're putting yourself at risk of starting a medication that will act on one pathway when you could just be like dealing with the delirious patient for an alternative reason. There's a few medical conditions you'd want to avoid it in. So severe hepatic dysfunction, most of the trials were saying it's an absolute contraindication to have cirrhosis with hepatic encephalopathy, as well as acute intermittent porphyria. You can't use phenobarbital in. There's a question throughout the literature of people kind of asking, is there synergy with benzodiazepines? This hasn't been really demonstrated anywhere, but it's just kind of a thing people raise. There's the known concern about respiratory suppression, and there's medication interactions. Most notably for us would be patients on HIV medications or hepatitis C treatment. With all that in mind, phenobarbital protocols are becoming more and more common. A trial in 2007 showed that when they implemented the protocol, there was a significant change in the way people would manage their patients and had positive outcomes with that change. With all this in mind, there are more and more protocols popping up kind of on the hospital level. So Vancouver, Toronto would be Canadian examples, and then Mass Gen and Harvard have developed their own, just to have a few in mind. Really, here in Hamilton, we don't have any formal protocol for people to use, but some of the addictions physicians here have been kind of using their own. And with their guidance, I'll kind of walk you through some of the thought process that would be used. So an example of a local protocol would be kind of first questioning, is this person a candidate for phenobarbital? Thinking of some of those practical considerations I just went through. Do you have a clear diagnosis? You're not worried about another neurologic issue kind of confounding what you're seeing. You've reviewed their medications as you would, and you've looked at their past medical history to rule out those specific conditions. Then the one example that's probably most commonly being used here in Hamilton by our addictions team is refractory alcohol withdrawal, where this person has been requiring significant doses of benzodiazepines, has high risk features and persistent and severe symptoms. You can then consider using phenobarbital as adjunctive therapy. Practically speaking, this would be kind of phenobarbital 30 IV TID, continuing on with your PRN benzodiazepine use as you normally would treat alcohol withdrawal. And then you should see reduction in symptoms and reduction in your benzodiazepine requirements. There is room to increase this phenobarbital dose, as you can see in the bottom of the slide. And then as you go through this, monitoring your cumulative dose and knowing when you should stop. The nice thing is that you can see as you kind of hit like 30 milligrams per kilogram, that's going to reliably lead to a serum dose of about 40 micrograms per milliliter, which as you get to 40 to 80, you start to see your respiratory suppressive and kind of toxic effects. So that should be your hard stop. And using kind of a soft stop would be more safe, where you're already considering alternative etiologies and are you missing anything? If you reach 30 milligrams per kilogram, from what I can tell, based on the literature, you have treated the alcohol withdrawal, and you're missing something else that is going on. Another example of kind of an alternative to that would be some people will recognize the high risk features of someone who has previously had delirium tremens, previously had alcohol withdrawal seizures, or had difficult to manage alcohol withdrawal, and then using PO phenobarbital upfront at a higher dose, so it would be 60 TID or QID, and then you can implement your PRN benzodiazepine therapy and then follow that same type of protocol as you walk through. So I think these are kind of things to consider about how could we add these into our practice as internists and not deferring only to the addictions team, and kind of how would we want to generate our own protocols for phenobarbital.
The last thing we'll touch on is sort of looking at alcohol use disorder after the acute setting. And so that would be after patients presenting with alcohol withdrawal. And so most of the literature breaks down alcohol use disorder into mild and then more moderate severe. And so in mild alcohol use disorder, the recommendation would be things more like psychosocial intervention. And what that would include would be things like alcohol counseling or mutual help groups. And then in the more moderate to severe category, this would be looking at things which would be psychosocial intervention with pharmacologic management. Next slide. And so when we look at the types of therapies available, I'm going to touch mainly on first line, which would be naltrexone. And so this would look at reducing our heavy drinking days and to help promote abstinence. And this can help patients with managing cravings. The other first line agent would be acamprosate. And then second line, I won't be going into, but that would be things like disulfiram, topiramate, and gabapentin. And so when looking at naltrexone specifically, this is a semi-synthetic mu-opioid antagonist, which decreases GABA inhibition and reduces dopamine release in the mesolimbic pathway. Importantly, this can be initiated during active alcohol consumption, and often starting dose would be 50 milligrams daily, and then this could be titrated up. There also is an IM formulation, which would be given every 4 weeks. Importantly, the contraindications would be any current opioid use or prescription for pain management, just given it's antagonistic for the mu-opioid receptor, and otherwise hepatic failure or elevated liver enzymes more than 3 to 5 times normal. Monitoring for these patients would be sort of liver chemistry prior to initiation, and then several weeks after initiation, and then about every 6 months after that. The response is variable and it sort of depends on your goals of therapy. And so that would be sort of, if the goal is to reduce drinking, well, then your sort of marker would be, have they been able to reduce their drinking? And then if the goal is abstinence, has that been achieved? The duration is around at least 12 months, and that would be sort of your marker to help reduce recurrence of alcohol use. And this is just sort of a quick pictograph of action of naltrexone, which again, I won't go over, but essentially looks at the mu-opioid receptors. And then,
So coming back to the case, I think that, you know, we were talking about this patient who had upwards of like close to 240 milligrams per day of IV diazepam requirements based on the dosing, was unable to be transferred to the ward, was quite agitated, couldn't take PO medications. So what might we do differently based on our discussions today with local addictions medicine physicians, as well as the review of the literature that we've done? So we would consider starting adjunctive phenobarbital at low dose IV-TID in this patient. So for example, 30 milligrams IV-TID. Hopefully this patient's benzodiazepine requirements would then begin to decrease over the next 1 to 2 days. And as they come out of withdrawal, we can then taper off the phenobarbital by 1 dose per day until they're off it to prepare the patient for discharge. Ultimately, this would hopefully result in an avoidance of ICU or monitored bed admission. And then this patient would be a good candidate for initiation of naltrexone, either prior to discharge or likely as an outpatient. So we'll just go over our conclusions.
So for conclusions, alcohol use disorder and withdrawal have significant system impacts and healthcare costs. We know that the CIWA protocol has limitations, including score subjectivity and underdosing of benzodiazepines. An objective withdrawal assessment may bypass these limitations. Phenobarbital is an evidence-based treatment that has a role in the management of high-risk patients and those with high benzodiazepine needs. In these patients, our hope is that the implementation of phenobarbital will reduce healthcare costs by preventing progression to severe withdrawal and thereby reducing length of stay and the need for monitoring in higher care needs settings. And lastly, all patients should be assessed for non-pharmacologic and pharmacologic therapy after the acute setting.
Thank you so much, Dr. Khattak, Dr. Winberg, and Dr. Gunka for this overview and review of the literature. I think we have quite a bit of time for discussion, which is great. If you have any question, please put it in the Q&A. I know Dr. Turner has answered a couple, which is fantastic. Thank you. And if you have any discussion, please put it in the chat. If you want to be brought in to have your question in person, please raise your hand and we'll bring you in, and we'll start with Dr. Holbrook, and I will get you in a second. Okay, please go ahead.
Thanks, Khaled. Thanks very much. So just as a declaration, I don't know if folks know because the alcohol withdrawal protocol is sold, but I wrote the alcohol withdrawal protocol. CIWA is just the scale that we use, but the protocol was written by me and a nurse educator about 30 years ago, and it has changed very little despite constant reviews of the evidence. So I'd like to just bring us back to the evidence because I think that's key. There is no doubt that we don't always treat alcohol withdrawal that well in practice, but I can assure you, as one of the few people that were around before the protocol, the improvement in outcomes because of the alcohol withdrawal protocol are dramatic. So people went on into delirium tremens or seized for days, without adequate therapy before. So the protocol has definitely improved. There's no doubt that there's subjectivity and there's interperson variability around CIWA scoring, and that's almost unavoidable without constant teaching and and reminders about how to score. But it's been very useful. So in constantly reviewing the evidence, because this comes up all the time, we have stayed with the protocol that we have, as you say, virtually for decades, and we actually. Having benzodiazepines available, it's interesting how history repeats itself. They were the golden drugs deliberately to get away from drugs like barbiturates, which have a much nastier overdose and adverse effect profile. So I would advocate very serious cautions about trying to bring phenobarb back, because the evidence right now is still very limited. So I want to caution people, just because we still have some poor outcomes, people go on into delirium tremens for some time, it doesn't mean that we should always be using additional therapies. Just a couple of specific comments. Lorazepam is the benzo that has fewer active metabolites. Diazepam is actually very long acting with active metabolites, and not quite as long as phenobarb, but safer than phenobarb. And in times of shortage, my plan, which I haven't to do yet, was if I got desperate, I would actually begin to use midazolam. We do definitely have issues with, can the patient be treated on the ward? I would have serious reservation about the usual protocol with phenobarb about saying, okay, now it's okay for that patient to go to the ward. Like IV benzos and IV phenobarb, I thought in both of our hospitals still meant an advanced care setting. I just want to caution you about something that has become kind of a given with the protocol that is not our intention. The 3-dose max was an administrative stop. So the 3-dose max is really just meant, can you go back and make sure that there aren't other causes for what you're seeing? You know, is this actually atrial fibrillation? I mean, we pick up atrial fibrillation all the time now, but in the old days, we didn't have as good monitoring. So it was really just a check and balance. It was never meant to say, stop the protocol. But it seems in some hands, it's meant to say, okay, well, you know, we have to do something else. That's not the case. So the 3-dose max was put in by administrators of the hospital. It's not really that well supported by the evidence, but for example, at HHS, it was based on one famous case where the surgeons were treating a patient with high-dose benzodiazepines for 2 weeks when it turned out they didn't actually have alcohol withdrawal. So, you know, this is what happens at our patient safety committees when there isn't kind of a constant review of the evidence. So you can go on past 3 doses. There really is no major problem. And you have to remember that the evidence is once a patient's in DTs, we don't have good evidence that anything shortens the DTs. That's why you treat with very high doses initially. This is all supported by randomized trials. That's why we have symptom-triggered therapy. If you give the high doses, the full 20 of diazepam, 4 of lorazepam, very early before they get to DTs, you're trying to abort them. Once they're in DTs, there's not very much you can do. So what I would like to see, if possible, I don't think this should just be loosed on the wards as this is now our standard of care. This is definitely something that we should study. So what I would encourage is, you know, this should be done within a research environment where we look at, you know, because the phenobarb is meant to be a small supplement to ongoing benzos. So, you know, I would advocate for some ongoing study, but I don't think that there should be a wholesale change in our protocol, you know, without sort of further evidence coming forth. Thanks, Helen.
Thank you. And you brought in a few points. I'm sure the speakers and the panelists may want to comment. We'll just open it up, see if anyone wants to jump in and comment to what Dr. Holbrook has shared with us. Leslie?
I'm happy to, but I'll let Shamal go first. I saw her unmute.
Oh, I was just going to mention about the max 3-dose point. It wasn't intended to say that we don't give doses beyond that, just that it is then up to the discretion of the physician, which most people, like including residents on call, may not be comfortable with high-dose benzodiazepines. So anecdotally has led to underdosing, not that we tend to stop there, just to clarify that point.
Thanks, Anne, for your comments, and I agree with many of them, as I'm sure Suzanne would. She's not in a place where she's able to unmute and speak. There's a lot to unpack there, so I won't address everything, but I agree that, you know, as our addiction service and in working with the residents on this talk, that we're not trying to get rid of the CIWA protocol, but just, you know, when are we running into challenges with the CIWA protocol in terms of driving those symptom triggered? And there's many cases I can think of that I've cared for in the past few years where people are able to overindulge certain symptoms and they end up with massive doses of diazepam sometime or Ativan inappropriately. And that's where the objective scores sometimes can be helpful as an alternate. And that's really how we've been generally using it, particularly in patients with mixed withdrawals. And as you said, often this comes down to the user of the score as well. And by sometimes removing some of those more subjective pieces, it can help us make it a little bit easier for the frontline team to be able to interpret those symptoms, particularly with complicated mixed withdrawal patterns like opioid combined with alcohol, for example. So I see this as an adjuvant, not a replacement, and that's quite case specific. And I think Suzanne would agree that the phenobarbital is similar, right? So seeing it as an adjuvant, not a replacement of our current protocols, but it's something we haven't used in Hamilton very much, and it certainly is being utilized routinely in select cases in other places in the country. And our service has a lot of ongoing retrospective, prospective studies. So I think it is a great place to really look, are we identifying patients that might benefit from this? And are we utilizing it upfront, as you said, to prevent delirium tremens rather than to react to delirium tremens? I saw there was a comment in the chat. The term delirium tremens is still being utilized. The last thing I was going to say is that I would certainly support them being in a monitored setting, maybe not ICU level, but we do have excellent step-down care beds across our city. And so that's, hopefully where I would see these patients land. And that's usually where they land anyways, so that they can be monitored. But all very important and excellent points. And the historic context is so important to understand about that particular case, because, often we're looking at our protocols saying, okay, are we too stringent? Because if the resident is tied up and doesn't respond to a call, we are seeing sometimes seizures happening because that next dose is not being given because of the check-in. But at the same point, we don't want 2 weeks of unmonitored ongoing benzodiazepine therapy. And how do we appropriately look at our protocols and find solutions that work in all contexts that are safe. And that's always a really difficult balance, because we're not just talking medicine patients, we're talking all, every patient across our network will be applied to these protocols when they're activated. Thanks, Anne.
That is one of the action items that we should take away, is revisiting that protocol, because there's two things that I've tried to resist over the years. One is some people feel very uncomfortable with the high doses of benzodiazepines immediately, and that's critical. But it should be high dose. Alcohol is affecting these receptors. You have to have high dose. The second is the 3-dose maximum, which I would like to, I think that's an excellent suggestion. We should look at options to allow that to continue where we're confident of the diagnosis. Because clearly there are, I see probably almost one a day alcohol withdrawal when I'm on service, because it comes selectively to me. So there definitely are people where, they're going to need ongoing therapy. I think we should resist the notion that just ongoing benzodiazepines to accumulation of a high dose is a bad thing. In some situations, it's required. And that is the drug that's going to, if anything, prevent seizures. It's just for DTs, it's not particularly effective. I think the final point we should be clear with everyone is, with withdrawal seizures from alcohol, you're already on high doses of benzodiazepine there. Phenobarb is definitely in the protocol, to treat those as well, and then propofol, but that obviously mandates critical care or some, monitoring.
Thank you, everyone, for touching really on the patient safety piece and making sure that we work within our hospital protocols. And I think, with this stronger addiction medicine services available in our hospitals today versus the days that those protocols were created, I think it's time to probably revisit. And working with Leslie and Robin, I think we could advance that within the hospital structure. But it's really important to let the residents, and I know that the question comes up whenever I'm on service as well, is like, why are we dosing it one time? And it's about that story that comes in, and and the patient safety. So emphasizing patient safety is this, and revisiting your diagnosis, similar to anything clinical you do, right? But there's time. There was a bit of discussion. I just want to reemphasize this, and there were questions in the Q&A, and I thank everyone who's answering those questions about the monitoring piece. And again, I think introducing phenobarb into a regular use requires a management of this complex health system with our nurses, and where they could monitor it and make sure everyone is comfortable using it and make it available. So that is, again, something that this wonderful grant routes will, help us take on and manage within our hospital structure. I don't know if there's another hand was up. There's none. So I think there are questions. Most of the questions in the Q&A has been answered. I think we can take Dr. Satya's questions about using Barbinex. And I think that's been answered already, but I don't know if anyone wants to comment on that. And I actually, he talks about using, yeah. So I'm not sure who's taking that question. I think, Barbara, you want to answer that one?
Yeah, it was just about the use of thiamine, which our protocols here do trigger whoever is filling out the alcohol withdrawal management protocol to give thiamine. However, if you want to do higher doses for more Wernicke's, that would something you would have to manually change yourself. But it does at least prompt you to give thiamine, I believe, for 3 days.
So Khaled, you still got me on the mic. It might be a risk that you want to chase, but there's another area where we need a study. We definitely need a study, and we could do a great randomized trial, probably finish in a year. So there's a lot of variability in what people think are the effective doses of thiamine, and we really only have evidence comparing 1 milligram to 200 milligrams. So in the alcohol withdrawal protocol, we settled on 100 because that seemed like that's definitely more than replacement requirements for regular alcohol withdrawal. The psychiatrists are completely convinced that if there's any nystagmus, which of course is very common in alcohol withdrawal, that's a sign of Wernicke's, and we therefore should give 500 milligrams TID. We really have no good evidence that that's the case. And occasionally thiamine is in short supply as well. So I would really advocate for a study in that area. I think that would be a great and a fairly easy study to do, trying to get a handle on what are the doses that are affected.
Thank you, Anna. That's very important area. And triggering studies out of these discussions are, what we aim for as academicians. So who's going to take it on, right? So fantastic. Actually, I want to bring in the discussion something that was actually asked in the Q&A, and I found intriguing is the max of 2 drinks per week recommendation for healthy drinking. I know it's not about withdrawal, but it's something like, we haven't started recommending to our patients, or maybe some of us have, so anyone wants to take that on and tell us how we can go into change management across the population to let them know that only 2 drinks per week is what we should be drinking.
I was looking at this guideline earlier this week and kind of thinking the same type of question of, I know when I told my friends that they weren't too excited. So how do you actually tell someone seriously about it? The interesting thing in the guideline is they talk about levels of risk. So historically saying that in a public health level, you accept about 1 in 1,000 risk when you're smoking, kind of unprotected sex or other risky behaviors. That's the general level that we kind of say people are happy to accept. And the previous alcohol use guideline was accepting about a 1 in 100 risk, so kind of significantly higher. So, I interpret it more as having more than 2 drinks at a time kind of places you at a significantly higher risk of accident and other negative behaviors. So I think I would lean more towards counseling on that than the kind of cumulative effect of 2 drinks over the course of 7 days as a long-term health consequence. That was the way I interpreted it more, and I feel like I could actually counsel someone in that manner more so than the long-term effect of it. But I don't know if anyone else has any thoughts.
So that's the topic I was assigned for the internal medicine review course. So I think what people have forgotten, the evidence has been around for ages, and I've been doing this type of counseling for decades. Alcohol is associated clearly with 7 cancers, and the cumulative exposure is important, highly associated with dementia. The accident, cirrhosis, basically risk of death is extremely high, all based on A, binge drinking, 5 drinks or more at a time, and B, cumulative ongoing drinking. So it's a huge societal problem. And I think it is part of our role. So after people have come out of withdrawal, that's the next thing we chat about is there any way we can, help you get down to low risk drinking basically. But what's really useful is the new guideline that, now low risk is what the evidence suggests actually is low risk, which is much lower than what we said before.
The other thing I'd add there, I mean, I had this experience yesterday with a patient who was feeling quite badgered about their drinking, is just being cautious about how we are going about those conversations and really making it patient-centered and like a harm reduction approach. So I just want to, mention that as well, is sometimes you really have to read your patient and work with them around what they think will be feasible, and either way a reduction will be beneficial. And so, I think of this all the time in terms of smoking cessation for my patients with the opioid use disorder. Like, we have to pick our battles and work with them around what they think is manageable. And so for me, for many of my patients, this isn't the place I would start with them, is getting down to the low risk. But how do we reduce that risk, minimize that risk, and support you around your goals as best we can? Because otherwise we'll lose a lot of people along the way if what we're striving for is seen, at least up front, as unattainable for them.
Thank you. I'm going to actually ask a basic question. Like it's Ativan or versus diazepam, and where did Librium really go? Why would never been used in our institution, where in Europe it's used commonly still? Any thoughts, like the choices, like why this versus that? And is there any evidence for either one to reduce the need for maybe going to use phenobarbital? You're looking at the literature, was diazepam versus any of the others, I personally like diazepam, so I'm not sure if that's for any reason other than maybe it works for me.
There hasn't been head-to-head comparisons. So the lorazepam or diazepam, I forget which was studied, was found to be a bit easier to use. And chlordiazepoxide went into shortage years ago. So lorazepam and diazepam came into common use. The reason we put both in the protocol is we consider them to be relatively equivalent. There is no problem using lorazepam or diazepam in liver disease. People often have this notion you have to use lorazepam because it's going to be safer in liver disease. We have no evidence to that, and it doesn't even make theoretical sense. Some people think diazepam gives you a slightly smoother withdrawal because it has active metabolites. Unfortunately, we don't have great evidence of that either. They're both long-acting. So in the end, both had been used in protocols. Lorazepam probably has a little bit better support in randomized trials, particularly around seizure prevention, but both are considered to be highly effective. But it's a good question. We don't have head-to-head comparisons of drugs that we have as choices, like is a problem in many areas. Midazolam has not been studied, by the way, just the full disclosure there. If we have shortages, midazolam does make a lot of sense, but obviously would require a higher level care setting, but it's definitely, there's no reason why it wouldn't work.
Thanks, Anne. I see a comment from Leslie about lorazepam and liver dysfunction because of the metabolites. Leslie, you can go ahead.
Do you mind if I just make another separate point? Sorry.
Yeah, sure, absolutely. Yeah.
So our service right now sees alcohol at St. Joseph's. So please feel free to consult. This is for the residents and Anne, who works at St. Joe's, and a few others on the call. Please feel free to involve our service as early as possible. But we are always there to help with these complex withdrawal patients, also at the HHS sites. Whether we can see them will be a little bit more context dependent, depending on volumes, because it is a busier service at the general, but we're always available to help out. So please do call us, and if we can see these complex withdrawal patients, even if they're pure alcohol, we will do our best. Otherwise, we'll provide some assistance for sure.
That's great, Leslie. Thank you for raising this point, and hopefully one day we'll be able to provide that service constantly at the HHS sites as well. See, Suzanne has a comment on diazepam loading is commonly used in Canada. It was at 60 milligrams on the for 3 hours. Yeah. And that's interesting. Suzanne, I don't know if you want to go into that in more details or someone else want to comment. I have not personally used that approach. Is it something commonly used to switch or should be commonly used to switch from one to another? Because sometimes, you know, even in our protocols, I should discourage you from, and that's again, that's something that we probably should look into, Leslie, as we look at our protocols again.
Yeah, for sure.
This is what addiction medicine physicians do. Something to consider when looking at the protocols.
I think what Suzanne's getting at is utilizing diazepam up front because of that longer half-life and kind of taking advantage of that, and then switching over to something with a slightly shorter half-life and less metabolites. Yeah.
Lots of things to think about. Thank you very much for I don't see any more questions or comments to go through, so we may be able to give people 2 minutes preparing for the next hours of the day. I thank you very much for this presentation, great engagement and discussion, actions for all of us to do on a scholarly work, as well as on patient safety and maybe impacting hospital protocols and change management in practice. So fantastic rounds. Thank you very much. And I'm not sure if there's anyone who has a final comment. Otherwise, we'll let you go with your day. All right, no final comments. Thank you very much, and have a great day, everyone.